Dear Chairman, ladies and gentlemen, allow me to thank Dr. Kazan for this kind invitation that allows me to be here, presenting to you something about the heart failure in Latin America. America has the North America, the Central America, and the South America. Latin America is constituted by Central and South America, and it has something like 600 million people, out of which Brazil is the largest country with 200 million inhabitants, followed by Mexico, Argentina, and Colombia, the major countries that belong to the Latin America. The problem we are facing in Latin America is this. We are in the middle of an epidemiologic transition. That is, we are moving from a time in which mortality was much due to carential infectious parasitic diseases, and we're moving into a situation of more urbanization, and with that we are diminishing physical activity. We are facing dietetic changes, stress, and smoking, and because of that, we are exposing our population to the well-known factors, risk factors for coronary artery disease, such as obesity, dyslipidemia, high blood pressure, and diabetes. So the major problem that we have now is that we are living with both situations. We still have remaining carential diseases, and we're facing a large burden of degenerative heart disease as the rest of the developed world. In comparison to what we see in North America, Latin America has shorter life expectancy. For instance, in North America, represented by the United States and by Canada, they are approaching a survival expectancy of around 80 years of age. In Latin America, we just reached 70 years of age of life expectancy. We have a higher rate of hypertension, as you can see here. So in our population, we estimate to have among the adult population hypertension rate of around 25% of the people. That's unlike what is seen in North America. Tobacco usage, we are doing rather well regarding tobacco usage, especially in Brazil. In Latin America as a whole, it's a little less than the United States, but in Brazil, we diminished considerably the tobacco usage, and we have a rate now of around 12 to 20% of our population that are smoking. And we have a high level of diabetes. The rate is around 10%. It's a little less than what's seen in the United States, as well as obesity. Obesity is certainly less than what's seen in the United States and Canada. But for instance, among female patients, they are approaching the rate that's seen in North America, but the male ones are diminishing, present less obesity, and it's estimated to be around 17%, unlike in the United States, where obesity is seen in around 30 to 35% of the men. So we have all this exposure to the well-known risk factors for heart failure, but we still have the burden from the carential disease. So if we look at the outpatient setting of individuals with heart failure, as we can see here from many studies, I'm sorry if you cannot see well, but let me point out to you that what we see in the outpatient department is that, yes, we have ischemic heart disease as an important cause, hypertension as an important cause, but we have an equal share of another disease that's peculiar to South America, which is the Chagas disease. So we have an equal share in the outpatient situation of ischemic hypertensive Chagas disease, and a little less, but still very important, valvular heart disease. We just finished a recent survey, relatively well done survey, which was constituted of over 1,000 patients that were, we just finished this, they were admitted. I want to call your attention to the age, which is less than what's described in North American, for instance. Our mean age was 64, 60% of women, in 51 centers in different regions of Brazil. The ischemic heart disease in the patients who are admitted with acutely decompensated heart failure are predominantly due to ischemic, is the most common cause, 30%. But let me call your attention to the fact that valvular disease is 12%, and Chagas disease in the recent years has diminished, but it still is 10% of the case. So let me take the advantage of the moment and let me introduce to you this concept of Chagas disease. This is an infectious disease. This is due to a protozoan, which is called Trypanosoma cruzi. It is Chagas disease because it's named after the discoverer of the disease, which is Dr. Carlos Chagas from Brazil, who discovered it in 1908. And he is well known for the fact that this is one of the rare conditions in which the same investigator discovered the agent, the pathway, the pathological process, and the main characteristics of the disease. That's why it's well considered to have the disease after his name. This disease is a disease of the rural area. It's a disease of the poor people. This is a disease of people who live in a very poor housing condition, because the disease is transmitted by a vector, which is a bug, that lives in this poor housing condition, usually close to the jungle area, and they are infected by, it's a Sylvester kind of situation. They are infected by rodents, and when they get access to the man, they bite the face of the man. That's why this bug is called in some places the barber bug. And with that, which is seen in every part of Latin America, except in the north of Brazil, it causes an acute disease. This acute disease is a result of the proliferation of the trypanosoma in the inflammatory cells, and from there it goes to the muscle cells in the heart, muscle cells, smooth muscle cells in the gut, in the esophagus, and in the colon. In the acute phase of the disease, it resembles a flu-like illness. It's not often recognized. When it is recognized, it is easily treated by benzonidazole, which is the product that eliminates the disease. But it's not easily recognized, and so it goes on. And when it does go on, it becomes indeterminate in the majority of cases. They'll have the serological evidence of the disease, but they will not manifest clinically during the rest of their lives. But something like a quarter of the patients will go on to develop a severe form of heart disease. Some of them will develop megas, mega esophagus, mega colon, but predominantly a cardiac form of heart disease in which you don't find the trypanosoma any longer. It's hard to find the trypanosoma. It's like a self-perpetuating, self-destructive condition mediated by autoimmune process in which there is a destruction of the cardiomyocytes and replacement by fibrosis, which leads to eventually a severe form of disease The heart is very dilated. There is a typical apical bulging, as you can see here, which is source of arrhythmias and emboli, systemic emboli, as well as severe heart failure. Patients with Chagas disease have the poorest prognosis as compared to the other forms of heart failure. They have poor prognosis than ischemic, than hypertensive, certain hypertensive heart disease, even valvular, because valvular occasionally can be treated. This is the curve of survival of patients with Chagas disease. That's the estimation we have right now for the Latin American. There is a 16 to 20 to 18 million people infected. In Brazil, we figure that there are 6 million infected. And out of those, 25% will develop Chagas cardiomyopathy in the next 10 years. The good news is that it's diminishing. So new cases are diminishing. The vector has been conveniently dealt with and has been eliminated progressively. But we have a huge burden of cases who are indeterminate and who develop eventually Chagas disease. Chagas disease is one of the most known neglected diseases of the world. So there is no interest from industry. There has been no interest in investment in treatment. And only recently we are engaged in this study, which is the benefit study, in which we are comparing treatment with benzonidazole in a chronic Chagas disease. In the acute disease, it's well demonstrated that it's highly effective. But in the chronic disease, it has never been done adequately. So we are doing it right now. This is an initiative of the Ministry of Health and in association with McMaster from Canada, and it's international multi-center prospective randomized double-blind placebo-controlled trial. We engaged already, we enrolled already 3,000 patients, and they were randomized half to benzonidazole, half for placebo, and we are in 2015 we will have the final results of this study, in which the primary endpoints are death, RS recovery, sustained ventricular tachycardia, pacemaker implantation, heart failure diagnosis, and thromboembolism. Let me call your attention to the endpoints that are different from other endpoints in heart failure. Why? Because arrhythmias are very prevalent in Chagas disease, as well as thromboembolism besides the heart failure. So we hope with that to have a contribution that will help the remaining 6 million people who still had been infected, and we hope that the program of getting rid of the vector will completely free us from this disease in the near future. I thank you for your attention.